Well, welcome everybody to our last 2020 SIPC seminar. I'm very excited to introduce our speaker today, Mei Hua. And Mei is an assistant professor in anesthesiology and epidemiology at Columbia University Medical Center. And her primary research interest is the intersection of geriatric critical care and palliative care. The overarching goal of her research is to improve the quality of geriatric critical care through the delivery of end-of-life care and palliative care using mixed methods to perform population-level analyses of outcomes and the ability to elucidate behaviors underlying practice patterns. I'm very excited. She's been an active member of SIPC. She's one of our, and she is mentoring one of our postdoctoral fellows. And so I'm very pleased to introduce Dr. Hua. Please go ahead.
Pat, thank you so much for that introduction. I'm really excited. I don't often get to present my work to palliative care audiences, so I'm pretty excited to be here. So, you know, you guys may or may not recognize this sort of cartoon that I've put up here, but what this is it's a sort of pop art depiction of Odysseus from the Odyssey. So the Odyssey is, you know, after the Trojan War, Odysseus is one of the great warriors that fights in the battle, and then he's got to get home. And the Odyssey is all about his long journey and all the trials that he faces. And one of them is this situation where he's got to decide whether or not he wants to steer his ship towards this monster behind the rock, which is named Scylla, who has 6 heads and is going to eat 6 of his sailors, or towards Charybdis, who's this whirlpool sucking monster who will just suck the whole thing up and then spit him back out. And the reason why I have this up here is because this really encapsulates kind of my motivation for doing the work that I'm going to show you today, is that oftentimes in the ICU, I just felt like we were in this Greek myth, where that our patients were in a situation where they were really caught between Scylla and Charybdis. And so what I hope to share with you today is my research journey about how I was trying to chart another path around, to try and figure out how we can use palliative care to find a new path. So quickly, just disclosures, I received funding for my research from both the National Institutes of Health, National Institute on Aging, and the American Federation for Aging Research. So the roadmap for today, what I hope to be able to answer in terms of the questions are, you know, who needs specialist level palliative care in the ICU? How can we improve access to those services? What other factors might affect the delivery of palliative and end-of-life care in the ICU? And then lastly, are all palliative care consultations the same intervention? So just to get right started off the bat, so in terms of the scope of the problem, palliative care needs are very common for patients in the ICU, both while they're in the ICU and after an ICU stay. So if we think about this broadly on a population level, about 6 million patients are admitted to the ICU every year in the US. Some small proportion, like 5 to 10% of those patients, are what we call the chronic critically ill. So these are patients who require prolonged mechanical ventilation. And we know that of these patients, 90% of them report having uncontrolled symptoms while they're in the ICU. About 10 to 20% of patients die in the ICU during their stay, and these patients, particularly those with cancers, are at risk for having a worse quality of life and quality of death when that's been studied. And even for patients who go on to survive the ICU, we know that survivors experience a litany of distressing symptoms, with fatigue and dyspnea being most prominent. And over the past, I would say 15 years now, there's been a whole body of literature that has really gone, really focused on sort of delineating what happens to people after they leave the ICU. So now we know that patients, once they leave the ICU, are at risk for having an increase in psychiatric diagnoses and medications, long-term cognitive impairment, similar to the level of sort of a pre-dementia or mild cognitive impairment state. They are at risk for functional disability. All of these things impact their health-related quality of life, decreasing that, and they're also at risk for increased mortality up to 3 years after their initial ICU stay. So I think that we can all agree that there is a high potential burden of palliative care need for patients who are critically ill. And in the ICU, palliative care can be delivered using several care models, and these are the sort of most common ones that we discuss. So there's the integrative model and the consultative model, and then when those two are used together, it's often called this mixed model. And that really mirrors the sort of division between generalist and specialist palliative care. So examples of the integrative model would be things like having order sets, pain order sets, protocols for withdrawal of life-sustaining therapy. But the idea is that palliative care principles are really woven into everyday ICU care. And then for the consultative model, this is probably what we're all much more familiar with, where we have a multidisciplinary team of specially trained consultants who come and deliver palliative care to the ICU patients. And really, there should be a division of labor here somewhat, where there's some more basic needs that are going to be addressed by generalists or the ICU team, and then we call in the specialists when we're having an issue with refractory needs or some complex sort of medical needs. And so if we think about this on sort of an overall level, ideally what we would do is we would screen ICU patients for having palliative care needs, provide some degree of generalist palliative care in varying levels of intensity depending on the need, and then for some small portion of patients, we would involve specialist level palliative care. And so what I've spent the majority of the past 8 years or so trying to understand is that small green circle, really, and trying to prove how we go about that process. And the first thing that I encountered was obviously that there are, as anybody who's in the ICU knows, there's quite a few barriers to the involvement of specialist level palliative care. And one of the first things that I came up with, and I would get this question all the time when people would ask me about my research and what I was doing, and they'd say, okay, well, that's great, but if I call palliative care, what are they really going to do for me? So at a baseline, there was just this unfamiliarity with palliative care and not really an understanding of what they could offer patients. So this is a study that we undertook to really try and get at that question, right? What do we actually use palliative care physicians for in practice? So this was a study where we took all patients at Columbia over about a 2-year period who were in the ICU and received a palliative care consultation. And the first thing that we did is we looked across the different ICUs and looked at the rate of consultation. And that varied from about 2% being lowest in the CT and neuro ICUs all the way up to 10% in the NICU. So there's definitely some variability there. And there may be multiple reasons for that. And then what we did is we looked at the reason for consultation that was specified in the note, and we just looked and saw what people were used most commonly for, or why the consult was called. And so 3/4 of the time, 75% of the time, palliative care consultants are asked to be involved in the care of ICU patients to address goals of care. Just slightly less of the time, about 2/3 of the time, they're being asked to support the family and support the patient. And about 1/3 of the time, they're asked to address symptom management. And so at least practically speaking, this gives us actual data to say this is what palliative care consultants, at least at this time, are largely being used for in the ICU setting. But I think what was really actually important about this is we looked also, so this was for the initial consultation, the reasons for initial consultation, but we also looked at what happened over the course of stay. And what we found is the vast majority, over 80% of ICU patients had additional palliative care needs addressed outside of what they were initially asked to address during the initial consultation, with about 50% of patients having some kind of recommendation made for pain management and 60% of patients having some kind of recommendation made for some other symptom management. So not only does it show us that this is what we kind of use palliative care consultants for, but that there's probably a lot of value to involving them beyond what we as ICU clinicians think they're good for. So that takes care or helps to address that one barrier. But another barrier that we have with this idea of specialist palliative care is how do we determine who these people are, right? Like how do we circumscribe the people that go in this green circle? And specifically, how many people are there? Who are they? How do we identify them? And then after we identify them, how can we increase their access to palliative care services? So this was a study that we undertook to try and answer that, at least one of the basic questions of how many people are we talking about, right? So this, and this uses the idea of what's called a palliative care trigger. So a trigger is a clinical criteria upon which once a person meets that criteria, they are supposed to be at high risk for having palliative care needs. And so at the time that we did the study, there had been several triggers that were published. And in general, they're they've been made by a sort of consensus criteria and expert opinion to identify patients who are either at high risk of death or high risk of having a continuation of non-beneficial life-sustaining therapies. So things that people had proposed were having stage 4 cancer, having had a cardiac arrest, having had an intracerebral hemorrhage and being mechanically ventilated, being admitted to the ICU after a hospital stay of 10 or more days. And so what we wanted to ask is, if we take these triggers at their face value and say that they're representative of palliative care need, how many ICU patients meet these kinds of triggers? You know, what's the potential burden of palliative care need? And so we undertook this study using a database called Project Impact, which was is a national database of ICUs, largely in the US. And so we had about 180 ICUs, almost 400,000 patients, and we were able to come up with a number of how many people met one or more triggers for palliative care consultation. And that number was 14%. And so this was the first time, you know, this was really, at the time it was published, it made a lot of sort of waves in the ICU community, because it was the first time that anybody had really quantified the potential burden of palliative care need and put a real number to that. I think the other thing about it that was important is that it wasn't a number that seemed either too little or too large, right? It was sort of a Goldilocks number. If it's too large, if it's something like 50% of patients, that's just not useful. And if it's too small, then we potentially would think, well, you know, sort of inherently, we know that the potential burden of need is there. And so what we also did, though, is we looked within this sort of population level data across different types of settings. So we looked across different types of ICUs, different types of hospitals, and different locations of the hospitals. And what we found is that, unlike a lot of other sort of literature on ICU care on a population that shows a lot of variability, there was a surprising lack of variability in this number. The percentage of patients meeting one or more of these triggers is really ranging here from about 13 to 16%. And that was really profound for me at the time, because what that meant to me, being somebody who cares about these things on a population level, is that as a healthcare system, we have to address these needs. And what we will need to do that are interventions that are wildly scalable, broadly implementable, because these patients are everywhere. You know, they're not, as much as we in the academic medical centers like to think so, they're not all co-located in one type of hospital or one type of area. So I think this presents a real challenge to us as to how we're going to deal with the palliative care needs of this population. So one of the things also about these different types of triggers is that they're not really the same in terms of how you would operationalize them. Some of them are quite easy, like an objective trigger that's ICU admission after hospital stay of greater than 10 days. I think we all can kind of easily identify who that person is. But there were some really subjective triggers too, like things like the death being expected during an ICU stay, or the patient is receiving fetal care. And so recognizing that those things were not equal, what we wanted to ask is, how many of these triggers do we actually need to use to capture the majority of the population? So what we found was that using just the top 5 triggers that were all sort of objective criteria, and so therefore easy to operationalize, we were able to capture 85% of the population, of the overall population, that met any trigger. And that really suggests that, you know, using these kinds of objective triggers will probably allow us to capture some of the more subjective ones that I think people inherently start thinking of when they think about what should be a trigger or what should be a criteria for palliative care use. And so the idea of triggers is really appealing because it allows you to sort of kill 2 birds with 1 stone. It allows you to identify these patients, and depending on how you use the information, once a patient meets that trigger, it helps you connect them to palliative care services. But will people actually use them, right? So we don't know. And so this was a study that we conducted to try and figure that out a little bit more. So this was a multi-center study conducted with investigators at Duke and University of Washington, and it was basically just a survey study where we asked critical care clinicians, ICU attendings, nurses, and trainees, fellows, and PAs, or advanced practice providers. And we asked them how they felt about triggers and how they would want to integrate palliative care specialists into the ICU. And so here in this figure that I'm showing you, the height of this black bar is just representative of how many people said that they would want to use any of these one ways for integrating palliative care specialists. And what the most common method that people chose was having these triggers integrated into the electronic health record. So 40% of people chose that. But I'll actually direct your attention over to the second and third highest bars, because what this is actually saying is that 46% of people actually wanted there to be some kind of interaction, whether it was formal or informal, between the palliative care and ICU team. And I'm going to come back to that. So remember that for a little bit later. So most of the time people wanted to either have some interaction, but people were also okay with these triggers. When we asked people how they would want this to be operationalized, like who do you want to do the screening, perhaps not surprisingly, the majority of people wanted the palliative care team to do that work, to do the screening work, followed by the ICU screen. And here the red and blue, blue is nurse respondents and red is physician and advanced practice provider respondents. So most commonly is the palliative care team, and then followed by the ICU nurse, followed by a combination of the physician and ICU physician and nurse. And so what was interesting is, not surprisingly, about 67% of people wanted to be able to approve any kind of trigger list before its implementation. But what was surprising is that after that prior approval, 55% of people said they would actually be okay if once a patient met that trigger, they would automatically have a process by which palliative care could be automatically called and automatically involved without another sort of conversation occurring. And that was a little bit surprising to me for reasons that I'll sort of get into a little bit later. So we also took a look and asked people how they felt about individual triggers that people had published. And so if we look at this right-hand column, this agree to disagree ratio, that's simply the number of people who thought that this would be a good trigger over the number of people that thought it was not a good trigger. And so the things that sort of had the most support as a trigger, you know, some of them were kind of difficult to operationalize. So stage 4 cancer, metastatic malignancy, that might not be quite so difficult, but having unrealistic goals of care or expectations, needing help with goals of care decision making, those things are, people really like them as triggers, but they're really difficult to operationalize. And the things that would be very easy to operationalize, particularly in an EHR system, things like having been mechanically ventilated or in the ICU for a certain number of days, being of a certain age, those things were fairly unpopular. So I think that what these data really tell us is that people like the idea of triggers. It's really appealing, but it's pretty difficult to operationalize and implement correctly. And so one other question that I always had, you know, I'm a really data-driven person, is whether or not we could sort of increase buy-in for the idea of these triggers by tying them to some agreed upon outcome, and whether or not we can have this idea of data-driven triggers. And so this was a study we actually did using New York State data. And what we did is we created a cohort of critically ill patients, and then we wanted to pick an outcome that we felt was really low-hanging fruit for people. So we picked 6-month mortality. And obviously 6-month mortality is usually tied into the initiation of the hospice benefit and not the initiation of palliative care. But we felt like this would be something that it would be difficult for people to disagree with, right? So if a person is at high likelihood of 6-month mortality, it's really probably a little bit difficult to argue that they don't merit criteria for palliative care. So the first thing that we wanted to do is look at existing triggers and look at their ability to predict 6-month mortality. So in this cohort of critically ill patients, we found that about 20% of people died within 6 months of their hospital admission. And when we looked at existing triggers and their ability to predict whether or not those patients died within the subsequent 6 months, we found that they had pretty high negative predictive value. And that's largely because the majority of patients aren't dying. So the negative predictive value is pretty good, around 80 to 85% for any one of these existing triggers. And the positive predictive value, which is how we would normally think about using this, right? If somebody is positive, we think they have a high likelihood of dying within the next 6 months. That was pretty variable depending on what the trigger was. So that ranged from 40 to 80%. For triggers that we were already sort of in existence. And so then the next step of this, what we tried to do to try to create data-driven triggers, was to isolate risk factors for 6-month mortality and then bundle those together to kind of create these high-risk subgroups to identify novel patient populations that may not have been identified in these previous studies. So what we found is that we were largely identifying patients who were older, and patients who either had sepsis or cancer. And so what we did is we generated in these high-risk subgroups what their predicted probability of 6-month mortality was. And you can really choose any cutoff you want. We kind of chose a cutoff around 50%. But if we look here, what we see is, so for example, if somebody is age 60 to 69 and they're admitted with any kind of cancer, not just metastatic cancer, their odds of dying within 6 months of that ICU admission is about 50%. It's pretty high. And of course, this increases as you age, right? So if you're 80 or greater, then you also have cancer. Your probability of dying within the 6 months after the ICU stay is 60 to 70%. And so I think here we are identifying some novel groups of patients who, using this methodology, this data-driven methodology, that have not been really previously identified. And largely it's older patients with sepsis. And I think the other distinction here that's important is, previous triggers had really focused on metastatic cancer, but I think what these data suggest is that it's really any cancer, and we don't need to worry so much about making that distinction about the staging, actually. And what we found is that these novel triggers that we identified, they had a very similar positive predictive value for 6-month mortality to those in existence. So I think the value of this study to me was that, I think it's just a proof of concept that we can certainly tie triggers to, or sort of the generation of triggers to some kind of outcome. This is important because this methodology is really portable, right? Like you can take this to any patient population, choose whatever outcome you want, and use this kind of methodology that we used here to identify novel triggers for palliative care consultation. And then the one thing that I would say is the big limitation is we still don't know whether or not tying these triggers to that objective outcome really is going to increase buy-in for them, but I think we proved that we can do it. So regardless of what happens once you identify a patient, right, we still have to a clinician at some point, after they identify that the patient is high risk, they still have to make a decision to call palliative care consultants into the ICU to come see their patient. And that decision process has always been something that really fascinated me. Like, what makes that happen, right? Because we as ICU physicians are generalists, we can do many of these things, although arguably not as well as palliative care specialists. What makes somebody sort of flip that switch and say, oh, I'm going to call palliative care? And so this was a qualitative study that we undertook to really try and understand that process and that the sort of what underlies that decision. And so we recruited ICU and palliative care providers. So this was ICU attendings and nurses, as well as any type of palliative care provider, any member of the palliative care team. So attending, NP, social worker, chaplain. And we did that across 2 different medical centers here in New York City, academic medical centers. And we looked and tried to sample across all the different types of ICUs within those 2 medical centers. We conducted one-on-one semi-structured interviews with those providers, and then we used a grounded theory approach, an iterative process with constant comparison, sort of very standard qualitative methods, to try and come up with a theoretical model of how palliative care specialists are integrated or adopted into the ICU. Basically, the question was, how do we achieve buy-in for involving palliative care? So we had about 36 participants and did 36 interviews. We have a pretty young population overall with a mean age of 38 years, about 8.5 years in practice, so fairly mature. Our sample was predominantly female and predominantly white. We did sample across all the different types of providers, and we were able to get a pretty good sample across all the different types of ICUs. And so this was the theoretical model that we came up with. And what we found is that there are really sort of stages of palliative care adoption in the ICU. This initial phase here on the left is really characterized by kind of a very, and it can be very quick, and actually I think can happen concurrently with this second phase, but it really just is characterized by the need for some really basic information. Basically, this is who palliative care is. This is what they can do for you. These are the types of patients you might consider them on, calling them on, and this is how you reach them. So very basic information. And then what's really key here is the second transitional phase that is sort of in the middle. And this was really where, or sort of the process by which buy-in was achieved. And when we asked people, what really makes you call palliative care consultants, they kept saying, I call them if I'm comfortable. I call them if I trust them. And that idea of comfort and trust was really built upon these 4 pillars. And so if we break it down a little bit more, these are just representative quotes for each of these ideas. The first was this idea of that a primary provider, really wanted to retain autonomy over that patient. So I think the issue with palliative care in the ICU has always been a little controversial because a lot of ICU physicians feel like they practice palliative care. So this is the kind of don't step on my toes, I'm still in control, right? That's the sort of vibe that people are getting. The second is to be collaborative. So most important thing is remaining collaborative with the primary team, seeing it as a unified approach, having open dialogue, listening to each other and debating, but in a respectful manner. That's how it works. This idea of becoming acquainted, this third pillar, was really the idea that palliative care and ICU physicians really needed to get to know one another, like as people, right? So a relationship isn't to a service, a relationship is to a person. So having those kind of personal connections is really important. And the last is pretty self-explanatory, the idea that if you've had a successful experience or a good experience with somebody, that you'd be more likely to call them back. So if you're happy with how they conduct the difficult family discussions and how both of you have done it together, you're more likely to use them. And I think what was really notable for me when I saw these data and they sort of came out was that if you look at what is really driving this, it's all about the relationship between the providers, right? There's not really that much talk about the patient needs or, what's happening with the family. It's really, this decision is based on the relationship between ICU and palliative care providers. And so that's something that's probably not what we normally think of when we think about palliative care need and who gets access to services. And so after that whole phase occurs, and you have buy-in for palliative care, we sort of reach this mature phase. And what we found at that stage is that once the buy-in is there, what actually limits the involvement of palliative care specialists is their availability. We would hear a lot of providers saying, well, I'd like to involve them more, but I don't think they have the bandwidth. And so at that point, once you achieve the buy-in, you're almost like too successful. And palliative care teams are often under or just not, there's not enough of them to go around, right? They're a scarce resource. So I think that it's a really interesting sort of problem to have, even when you have gotten the buy-in, you're probably not able to do what people want you to do. So just to summarize and sort of regroup here and take a breath. So what I've tried to convince you of or show you thus far is that palliative care needs are very common. 14% of critically ill patients meet one or more criteria for palliative care consultation in the ICU. So the idea of triggers and these kinds of checklists for palliative care, they're actually appealing to clinicians, but some of the triggers that are most palatable are really difficult to operationalize. Triggers can be sort of validated, with my air quotes, validated by being tied to an agreed upon outcome, but we don't know whether or not that actually will increase the buy-in for them. And then lastly, the use of palliative care consultants in the ICU, their sort of adoption really depends on the relationship between providers. So it depends on sort of having respect for each other's autonomy, working collaboratively, prioritizing the ability for teams to directly be in contact with one another and get to know one another, and then emphasizing prior successes. So now that we've done all that, so moving on. So this next question that I really wanted to ask, and I've kind of hinted about it a little bit, right? So what other factors affect palliative and end-of-life care delivery for critically ill patients? We've just talked about how, the relationship between people, and so people who are more people person kind of people might be better at getting consulted in the ICU. But what are the other factors that affect delivery of palliative and end-of-life care? So I think, I showed you this as a very obviously simplistic model of palliative care delivery or palliative care need in the ICU. But what it ignores is that there's actually all these external factors, right, that might affect how we choose to deliver palliative care. And so this was a very pretty early study that I did that tried to ask that question and tried to look at how our environment might affect how we deliver end-of-life care in the ICU. And so within the ICU world, there's this idea of ICU strain, which is, in layperson terms, it's basically how busy an ICU is. And so the question that we wanted to answer is, does that environment of how busy the ICU is, does that affect how we deliver end-of-life care? So if we look here, this is kind of a conceptual model, right? So we have ICU strain, or how busy it is, and that's actually operationalized in 3 variables: the number of admissions, the census of the ICU, so how fully occupied the ICU is, and then how sick the patients are in the ICU. So that can conceivably affect how the time to death, or how we deliver end-of-life care. In particular, does it affect sort of time to us having discussions and instituting limitations in life-sustaining therapy, or is it that we're so busy and so we're delivering worse care and therefore people are dying? Or maybe we don't have the time to have these discussions and then people are dying slower. And I will tell you that we went into this study with competing hypotheses. That half our study team thought it was going to be, the time to death was going to be shorter, and then half of us thought it was going to be longer, because it takes time to have these conversations. And so this, again, was a study using project impact data. We took a cohort of decedents and really looked at how strain was associated with these 2 variables. And I will tell you, unfortunately, that I was on the losing end of this. So I thought that it was going to take longer, and it was not true. Pretty universally, when the ICU was busier, so in higher quintiles of strain, time to death and time to having a DNR put in place was faster. Okay, so patients, and so what we did after that, and so what you're looking at here is the effect is about like a day and a half faster. And so then what we did to really sort of solidify that this was part of the causal pathway, that it was happening through the limitation in life-sustaining therapy, is that we did a mediation analysis. And so that really is supposed to suggest that what's happening is that we're instituting the time to DNR, and that's why patients are dying faster. And what we found is that the mediation effects were very strong. So 65% of the effect of having higher admissions was mediated by time to DNR in terms of time to death. And then basically the entirety of the effect of acuity was mediated by the time to DNR. And so what that really suggests is that when the ICU is busier, we have conversations and institute these limitations faster, and that's why people will die faster when the ICU is busy. And further supporting that was the fact that we did not notice in the cohort of patients that didn't have any limitations in life-sustaining therapy before their death, there was no association between strain and their time to death. So I think that's some suggestion that the ICU environment in general and what's happening sort of at that time can affect how we deliver end-of-life care. And so this was a study that allowed us to look at that a little bit differently. So here we were taking a look at a cohort of hospitals in New York State, and what we were really looking at is how treatment intensity was different amongst patients who received care in a hospital that did or did not have a palliative care program. And so all these, so this was a cohort of critically ill patients from about 150 hospitals in New York State. And to be clear, the exposure that we're looking at here is that they received care in a hospital that had a palliative care program. So it's a hospital level or ecological exposure. And so not surprisingly, there are some pretty big differences between the hospitals that don't and do have palliative care. The ones that do are more likely to be teaching hospitals. They're likely to be bigger hospitals, so have more than 400 beds. They see more patients, do more surgeries, have more physicians and nurses. They're just bigger kind of in every way. And so what we looked at is the association between receiving care in a hospital with a palliative care program as opposed to without. And we looked at a whole host of these sort of treatment intensity outcomes. Basically, our primary outcome was length of stay, and then we looked at a procedural burden as well as the likelihood of being discharged to hospice. And so what we found is that there weren't really any significant differences in the majority of these outcomes. There's some statistically significant but not clinically meaningful differences in length of stay. But what we did see a significant difference in was the likelihood of being discharged to hospice. And so this is a very small absolute risk increase, but it's a moderate relative increase. So patients who received care in a hospital with the palliative care program were about 50% more likely to be discharged to hospice. And being discharged to hospice from the ICU is a pretty difficult thing. It's probably a pretty narrow population, but it was significantly more likely to happen if you had a palliative care program. But what was more interesting to me when we look at this, because this is sort of a population level 150 hospitals, right? So it shows me that the effect is measurable, but then when we look across the different types of hospitals, right? Because we said that hospitals with and without palliative care are pretty different. When we do these stratified analyses, what we see is that that effect of palliative care being associated, availability of palliative care being associated with a hospice increase is entirely limited to teaching and large hospitals. And in particular, if we start looking at larger hospitals, we also see a significant effect in decreasing sort of these invasive procedures, right? So tracheostomy and gastrostomy tube placement is also significantly less likely. And these are clinically meaningful differences. And so there seems to be something where there's a difference, at least on a hospital level, between what's happening if palliative care is available or not. And so this was looking at patients who were already in the ICU, right? So there's a limited amount that you can do in terms of limiting the amount of intensity of treatment that people get once they've hit the ICU. So the other flip side to that naturally is, can I prevent ICU use from ever occurring? So this is sort of the follow-up study that we did asking that question. So we took a cohort of patients, again from New York State, and we looked at patients who died during their hospitalization and then saw whether or not they received ICU care during that hospitalization. And here, we changed our exposure a little bit. It's still an ecological exposure, but here we're looking at the implementation of hospital-based palliative care. So what this really means, so this is a sort of generic schematic of the analysis, so that it kind of explains the type of analysis we did. This is a difference in differences approach, which is an econometric type of approach. But what we're doing is, if the hospitals in red are the hospitals that implemented or started a palliative care program, we're looking at the change in outcome, ICU use, before and after implementation, so over time in those red hospitals, and then we're comparing that change in that outcome to the change that occurs over time in the control hospitals, which are here depicted by the green hospitals. So those are hospitals that never have a palliative care program. And so in our study cohort, we had 27 hospitals that never had a palliative care program, and then 24 that decided to begin a palliative care program during the 6-year study period from 2008 to 2014. About half of the patients received care in hospitals that did and didn't implement a palliative care program, and for those that were receiving care in a hospital that implemented a palliative care program, there were some differences in their demographics. They were more likely to be Black and live in sort of urban areas, more likely to have private insurance, and more likely to have sepsis. But other sort of gross measures of severity of illness and comorbidity burden actually didn't differ between these patients. So what we found is that when you do implement palliative care, it is associated with a significant decrease in ICU use, about a 10% decrease. And this absolute decrease is about 3.5%. And so while this is a sort of, again, a small absolute effect, you know, because there are so many patients who are admitted to the ICU sort of during a terminal hospitalization, and so many patients that die, when we sort of scale this up, these back of the envelope calculations, we were able to sort of suggest that this small 3.5% decrease in ICU use would actually translate annually to a cost savings of $265 million in the US. So even though it's, you know, this is what's great about doing population level work, is these small differences can have a really large impact and effect. So I think that because of that, sort of a, you know, got a lot of attention for having this idea of cost savings at the end of life. So again, because there are some pretty significant differences between the hospitals that do choose to implement a palliative care program and those that don't, we did these stratified analyses. And what we find again here is that effect of implementing palliative care decreasing ICU use during a terminal hospitalization is isolated to large hospitals and teaching hospitals, right? And so here again, we see that there's this heterogeneity of effect, that the effect is not the same. And I think that, you know, the plug again that I have for population level data is that you wouldn't be able to see this in smaller studies. It just is not something that you could do. And so what does that actually mean? Because really here, it's a hospital level effect, but this actually could be either a hospital level effect or a palliative care program level effect, right? Because in this analysis, they look the same. They'd be the same thing. So when we think about the other factors, that sort of leads nicely into this last point that I have here, right? Are palliative care consultations all the same intervention, right? Are there these kinds of differences? Does everybody need the same thing? So going back to this initial study that I showed you that just looked at palliative care, patients who received a palliative care consultation in the ICU here at Columbia, what we noticed is if we look at these sort of specific reasons for palliative care consultation across the different types of ICUs, there's actually quite a lot of variability between who's calling for what, right? So symptom management ranges from only 16% in the CTICU up to 40% in the MICU, or being called for withdrawal of life-sustaining therapy, or advanced directives and hospice referral. These are also wildly different between these different types of ICUs, okay? And that might be because of the differences in patient population. It might be because of differences in providers and what they need help with. Whatever the reason is, clearly, they're not always being asked to do the same thing. And so we wanted to see if there was a bit more of a data-driven way to kind of figure out what are the different sort of phenotypes of palliative care need in the ICU setting. So this study, again, uses data from Columbia, from ICU patients who received a palliative care consultation over about a 2-year period. And we did this analytic technique called the latent class analysis. And I think you guys heard about latent class analysis from Komal maybe a couple weeks or month ago. But what latent class analysis does is it sort of statistically sorts people into these different groups. And so what we did is we looked at the different palliative care needs and tried to sort people into different phenotypes or classes of palliative care need. And we came up with this 4-class model. And so I'll take you through this diagram here, which can be a little bit confusing, but basically on the x-axis are all the different types of palliative care needs. And then the different classes that we came up with. So patients in that class would have a higher than average for the cohort need for that particular palliative care problem. So here in this sort of circle line is the pain and symptom management, right? So these are patients who primarily are being called for pain and symptom management. The square are people who are primarily have a need for goals of care and advanced directives discussions. The triangle line is the all needs group, sort of what I lovingly refer to as the hot mess group. They're just high on everything. They need everything done in every domain. And then the last was really being called only for supportive care. That's sort of the X line. And so then what we did is once we sorted people into these classes, we looked and saw if there was an association between belonging to a certain class and what their palliative care resource need was, meaning how many palliative care visits did they require. And so we defined high resource palliative care need as being in the top quartile of palliative care visits, which ended up being 5 or more visits. And so what we found is that there really did seem to be a significant difference between these classes and the need for sort of intensive or high resource palliative care. So in comparison to patients who really primarily required goals of care and advanced directives, all the other groups were significantly more likely to require sort of prolonged palliative care or high intensity palliative care. And then if we look specifically at the different types of clinicians that were seeing these patients, we also see differences, right? We see that in people who were in this all needs group, they were significantly more likely to be seen by the MD and NP, and patients in the supportive care group were less likely to be seen by the MD or NP, but they were much more likely to be seen by both the social worker and the chaplain. So this already really tells us, I think, what we in palliative care already know, that palliative care, it's not a singular intervention, right? Palliative care clinicians and teams already are being very flexible, flexing their resources to sort of meet these needs in a different fashion. But I think, you know, the reason why I think this was important to put out there is that when we talk about palliative care and what it does, it's obviously a very complex, multifaceted intervention. And I think one of the things that may be a reason for why some of our interventional trials have not quite been as successful as they could be, is because we're not allowing for this kind of heterogeneity in palliative care need and what palliative care does to be appropriately matched to the outcomes that we measure. So this was a sort of very preliminary dive into that question that I alluded to. Do palliative care programs do the differences between them actually result in differences in patient outcomes? And so this was a very preliminary analysis that I did using New York State data paired with data from the NPCR, which is the National Palliative Care Registry, which is a voluntary program where palliative care programs will submit their data to the National Palliative Care Registry. And so some of the things that we were able to look at is we were able to look at the penetration of a palliative care program, and then how well staffed that palliative care program was. So penetration is defined as the number of consults that they see over the overall number of admissions. And so for programs that are in the highest quartile of penetration or the highest quartile of staffing, so again, these are very ecological analyses, what we see is that there is an association that seems to say that palliative care programs that see more patients are more likely to discharge patients to hospice and less likely to have these sort of burdensome procedures performed in critically ill patients. And then also and that's also true for patients, for programs that have higher levels of staffing, right? That they are able to, or there's an association between higher staffing and a decrease in sort of this operationalization of treatment intensity. And I think that suggests, right, that it's not just having the palliative care program, it's how it's implemented and what that palliative care program can actually do. And that these things actually might make a difference in terms of the patient outcomes. So in terms of questions for the future, and I think where do we need to go with all of this, I think that we still need, I think, to figure out what the best outcomes are to measure sort of the success of a palliative care intervention or the effectiveness of a palliative care program, particularly on a population level. I think obviously I've sort of played up the idea that, there are differences in hospital environments and palliative care programs, and those things might very much affect the successful delivery of palliative care. And then lastly, we know that palliative care is not a singular intervention, and so does everybody need the same intervention? And how do we start to think about parsing that out a little bit more? So just in conclusion, I would like to remind you that palliative care needs are very common in the critically ill population, with 14% of patients meeting published triggers for palliative care. The idea of triggers and also so using triggers for consultation and also improving the relationship between ICU and palliative care providers may help to increase critically ill patients' access to palliative care services. Non-patient-related environmental factors may impact the delivery of palliative and end-of-life care. And delivering palliative care is not a singular intervention, and variation in how it's implemented may really affect its success. And so I think improving palliative care outcomes really might require a better understanding of how palliative care teams operate in different contexts. So different areas of the hospital, different hospital environments, and different hospital settings. And so I just want to say a quick thank you to my mentors and collaborators and everybody who's helped me to generate all of this data. And then I'll take any questions.
So, oops, video's not on. May, that was absolutely great. And privately, people were telling me in the chat, how much they enjoyed your talk. So, and there are questions. And Christine DeForge had one of the first questions. Christine, do you want to ask a question?
Yeah, sure. I was just curious, one of the first studies that you were talking about where you evaluated all of the palliative care consults at Columbia, I didn't know if at that point could anybody consult the palliative care team, or did it have to be initiated by an ICU provider? And if anybody could a nurse initiate a consult? And did you look at differences between who reached out to palliative care?
Yeah, so we were not able to, because that was palliative care note data. So you do have a referring provider, but it ends up always being the attending who's on service. What I can tell you practically speaking is that the attending is largely in control of that decision. particularly in the procedural units, so the surgical CT ICU, potentially neuro ICU. It's not just the ICU attending, it's also that surgeon who co-manages that patient is largely in control of that decision. So it really largely is an attending level decision. And I can I could talk for a really long time about the politics or dynamics of how nurses feel about that.
Great, thank you so much.
Christine is an ICU nurse, so I'm sure she knows it well. And then Dan had a question, and it came up, other people were chatting with me while you were talking about across care. So Dan, do you want to go ask your question?
Sure. That was a great talk. It really sparked a lot of ideas with me. I'm interested in looking at palliative care earlier in the trajectory of illness. The ICU is great because you think people are have such acuity that we need to really focus on the medical solutions to why they're there. But, earlier palliative care also has good outcomes. The trick is actually getting people into palliative care early on. And so I didn't know if you had any thoughts about what you did in the ICU level. Do you feel that might be a path in order to figure out who needs palliative care in the community and getting them hooked up with outpatient palliative care sooner?
Yeah. I think anybody who works in the ICU feels that way. And I think everybody in palliative care has been feeling that way, that we do need to move things upstream. I think the world of advanced care planning is finally getting to a point where we're starting to see some positive effects. I think we've also had some really disappointing studies, and we know that these things are really difficult to change. Unfortunately, I do think it's going to be really patient population specific. I think one of the other challenges that I see in this, that's sort of the elephant in the room, is that I do think that depending on how we do these studies, that involving palliative care does really seem to have an overall signal for decreasing some of this burdensome treatment at the end, particularly at the end of life. But how are we going to actually get palliative care specialists to see all those people? We don't have enough of them, right? And so the reason why I think it needs to be or population specific to the disease process is that the disease trajectory in terms of when people are really end stage, I think varies so much by each disease process. And then we go ahead and do things like invent VADs and checkpoint inhibitors that throw all of that off. So I think that, determining at that stage where it is and is pretty difficult. But I actually think the biggest issue is how to get the people to staff it.
Yeah, important. Are there other questions? I certainly have a few questions for May, but does anybody else want to ask anything?
I don't want to ask anything. This is Marlene McHugh, May. I started the palliative care service many years ago at Montefiore, and we were very instrumental in integrating with critical care within our first 6 months. Mm-hmm. And one of the things that you mentioned, and I think it's so important when people are thinking about the future, the ICU, like the ER, are very different cultures. Mm-hmm. And what I learned early on was that I needed to be very careful about what providers I put into the ICU, because I could blow developing a service. And we were very conscious. We only put in providers who had critical care nursing backgrounds, mm-hmm. or had strong clinical backgrounds, because they were tested.
Yeah.
And they were challenged by the ICU team. And so when I see your data on pain and symptom management, that was one of the things that I was constantly challenged on by the ICU team. Mm-hmm. Once I knew that, I was considered credible.
Yeah.
So I think that that's really important when we look at palliative care providers and developing programs. You have to have providers matched with a clear understanding of the medical management to be successful. It's my experience also in primary care with geriatricians. Mm. If you don't know the geriatric system and what's happening to that patient, you're not considered credible. So putting providers in places where they don't know the medicine and symptom management and maybe are very good at advanced care planning may not work with development of programs. So that was my early lesson early on in the SICU also. Got to match people where they need to be. I had critical care attendings tell me that I had to remove any family medicine attendings to come into their ICU.
Yeah.
Thanks, Marlene. Jingjing Shang is having some background noise in her house, so she doesn't want to ask this question, but she wants to know whether you know of any literature of healthcare providers' knowledge of palliative care. Just over all healthcare providers? I'm not sure of the question, Jing. Maybe try a little bit, come off for a minute.
Yeah, I'm sorry, my kids was too loud in the background. So I was trying to, we are trying to see if, like, in general, any measurement of the healthcare providers' knowledge of palliative care. If not any, like, we really want to know, we know there's nothing in the home healthcare setting, and we want to develop a measurement to assess the home healthcare nurses' knowledge of the palliative care. But we do know if there are any, like, similar literature for the other healthcare, so like ICU, or like in general hospital settings.
Yeah, what I'll say is that I think most of the literature that I've seen about that does revolve largely around ICU nurses and whether or not they have received education or what their sort of knowledge is about palliative care, and therefore how comfortable they feel delivering generalist palliative care. Because as we all know, in the ICU, really who's delivering generalist palliative care, it's the ICU nurse. Right, they're the ones that are talking to the families, treating the symptoms directly, telling, giving the feedback to the other clinicians about, like, whether or not this intervention is working or not. So I think most of what I've seen is about that. I don't know that there's a formal tool. I think people ask, you know, some things like, have you received formal training in palliative care? Have you ever taken, like, classes or done CME in palliative care? And then some of it is just like assessing baseline knowledge, but I don't know of an actual, like, validated assessment tool for palliative care knowledge.
Yeah, well, interesting. Komal and Ashley and I did some preliminary research. We find the existing tool from other countries like Japan, Thailand, and so we did not see anything from the United States. So that's what I was wondering if you know anything.
Yeah,
but thank.
Well, thanks. We're going to quickly, I had lots of questions, but I'm going to talk to you about them. May, I'm very interested about what you think about sepsis, because we do a lot of work around infection prevention and keeping people out of the ICU from nursing homes and things.
Oh, yeah.
I can talk to you about that later, about what you think. And I do want to make an announcement. First of all, thanks everybody for attending. And I hope you have a happy and healthy holiday season. I know it's difficult for everybody now. I also wanted to tell you that we do have a spring lineup. We don't have all the things. We have Judith, help me. We have Ab Brody coming in February. I don't know the date off the top of my head. I should, but I don't. So please excuse me. We have Jean Kuttner coming also, so she'll be one of our lunchtime speakers. We have our pilot projects are going to be giving presentations. And then we have a foundational workshop, and that'll be a little bit longer. That'll be in May. And that's going to be
May 6th. Yeah, I'm sorry, May 6th. And we're going to have a call for poster submissions. And the speakers are going to be keynote speakers, Felicia Knoll and Billy Rosa, and the poster presentation moderator will be Betty Farrell. We're going to be sending this out to everybody who's attended today, so keep an eye out, please.
So thank you, everybody, and thank you so much, May. That was a fabulous presentation. So thanks.
Thank you for having me.
Okay. Bye-bye, everybody. Happy holidays.